1 second. Anyway, just look at this picture, that how we do the Heimlich maneuver. Let me show you. देखना बेटा अभी. चलो कोई बात नहीं, it's okay. We'll show it from here. एक मिनट रुकना. Now what happened to this child? This patient is. Yeah. दोबारा कर रहे. करूँ? Mirroring. Done. Yeah. अब आ रहा है? ये चल रहा है. I think इसी में प्रॉब्लम आ रहा है. Anyway, कोई बात नहीं. That's okay. Anyway. Now please see, now this child, this is MCQ actually which has been asked in such a way that the patient was having food or lunch or dinner, whatever. They make a story like that. And then the patient suddenly gets choking and aphonia. Imagine you're eating biryani, you know, and suddenly you feel choked up and you're unable to breathe and you're unable to speak also. What happened? A piece of mutton or chicken got stuck between your vocal cords. So read your notes better. This is due to food particles stuck as laryngeal foreign body. And for this, we have to do a maneuver to push the foreign body out, and that maneuver is called the Heimlich maneuver. This is Heimlich maneuver. That's a Heimlich maneuver. Come here. What we do is, for example, if this patient, and this patient is not like this, this patient is like about to die, because it's choked up. Like, so what we do is we stand behind the patient and we just keep our hand over this. Like you can keep like this also, or you can just do like this also, and keep the edge of the hand over here on the epigastrium, and push it backward and upward. Don't press the chest. Don't press the chest. You push this epigastric area, and you just push it back and up like this. Back and up. What you're trying to do, you are pushing the diaphragm upward. Diaphragm. This is diaphragm. Diaphragm goes upward, and thoracic pressure rises, and the foreign body is pushed outward. Basically, you want to push the diaphragm upward so that the thoracic pressure rises and the foreign body is pushed out, and the patient is saved. Huh? But if it fails, you do it how many times? 4 times. 1, 2, 3, 4. 4 times. And if it doesn't work, then read the next line. Then we do what? Cricothyroidotomy. Then we do what? Cricothyroidotomy. Have you read your notes? Can you see this visual question? What is the name of maneuver? The hands are on the epigastrium and the direction of pressure is upward and backward. Upward and backward, so that the thoracic pressure rises and the foreign body is expelled out. Am I clear? Fine. So this is the Heimlich maneuver. Don't forget this diagram. This can be a visual question for your exam also. What is the name of maneuver being shown in the picture? Okay. And read your notes also. If this fails, then we do cricothyroidotomy. Cricothyroidotomy. Anybody who remembers cricothyroidotomy? Remember cricothyroidotomy? Cricothyroidotomy means what, beta? When you open it from here, you put a tube and give oxygen to that. You do that, and after some time you do a laryngoscopy and pull the foreign body out. But to save the patient, if Heimlich maneuver fails, then you do cricothyroidotomy. If you remember, this was an emergency airway procedure which can be done by opening the cricothyroid membrane over here. Okay, fine. Cha. This is about a general question, about a scenario-based question. Okay, fine. Heimlich maneuver. Okay, bache. We'll take a break here. The good thing is the break. The best thing is the break. It's a 15-minute break, the last break of the session. And then after that, we do the remaining part of larynx, and then we start the pharynx also today only. Okay, fine? Chalo. Good. So see you again after 15 minutes. If you have any question, please post it in the chat box. Okay, sure. Hello guys, welcome back. Now let us take the discussion further, beta. Yeah. So that's the channel we were talking about, the Telegram group. And this is for Fmge. There are two groups in Telegram. One is for Fmge, one is for NEET PG, INICT. As of now, you join the Fmge group and post your question over there. We will discuss it. There are a lot of things posted already. There are a lot of things are there. If you go up, you will get a lot of one-liners and questions and all that. And, you will get it over there. Okay. So let's be in touch actually, not just for these 3 days. After that also. Okay. Now the next topic, beta. Everybody, let's start the next topic. The next topic is voice disorder, beta. Voice disorder. Voice disorders, beta. Next topic is voice disorder, beta. Open up voice disorder. Voice disorders. Number one is mogiophonia. Everybody open up your notes, beta. Voice disorder, number one, mogiophonia. Mogiophonia is speech problem in public appearance only. Speech problem in public appearance only, beta. Speech problem in public appearance only, beta. Speech problem in public appearance only. Speech problem in public appearance only, beta. Speech problem in public appearance only, beta. Okay. Public appearance, for example, on mic, write down M for mogiophonia, M for mic, write down M for mogiophonia, M for mic, mic. Mic पे होता है mogiophonia, M for mic, beta. Basically, no problem. When I'm talking in friends, I'm absolutely perfect. But when I talk to strangers, when I'm standing on the stage, I'm holding mic, I get so confused, I get so anxious that I stammer on the stage. मैं stage पे हकलाता हूँ. I stammer on the stage, beta. I stammer on the stage. I think no good. करना बेटा. Yeah. Yeah. So mogiophonia is speech problem in public appearance only. How to remember it? M for mogiophonia, M for mic, beta. M for mogiophonia, M for mic, beta. Mic. So it's a psychological problem. You are too conscious of other people and you get confused on the stage. When you hold the mic, doctor, I am otherwise absolutely normal. But when I am standing on the stage in front of strangers, I get so confused that I stammer on the stage. It's not a laryngeal problem, it's a psychological problem. But because it's phonia, I wanted you to understand. Mogiophonia means speech problem in public appearance only, beta. Okay, fine. So how to remember? M for mogiophonia, M for mic, beta. It happens on the mic. Okay, it happens on the mic, beta. Now, next one. Rhinolalia aperta or hypernasality, beta. So this was the voice disorder. Put on number one, mogiophonia. Number one is mogiophonia and number two is rhinolalia aperta. We are doing the topic of voice disorder, beta, voice disorders. Rhinolalia aperta is hypernasality of voice. Hypernasality of voice, beta. Nasal element is too much, beta. Nasal element is too much, everyone. Hypernasality. Look at me, beta. Look at me. Hypernasality means nasal element is too much. If you remember, there was a Bollywood singer. Nowadays he's a judge actually. Most of the time he's judge. In various shows. His name is Himesh Reshammiya. Himesh Reshammiya, remember? Himesh Reshammiya. He has got a very nasal sound, hypernasal sound, and that's, if you want to understand rhinolalia aperta, think about Himesh Reshammiya actually. He's a hypernasality of voice, beta. Now, all of you say Baba, Baba, Baba. Now say mama. Look at my lip movement, beta. Baba. Look at my lip movement, beta. Everybody look at my lip movement. Baba, Baba, Mama. Baba, Mama. And both of them have got the same kind of lip movement. Baba, Mama. No difference, beta. No difference. How can the same lip movement produce two different types of sound? If nose contributes, the nose air contributes, the sound produces mama. Mama is nasal contribution. If nose does not contribute to the sound, it is baba. Baba, mama. Baba, mama. Okay? So what decides will the nose contribute or will the nose not contribute? Palate, beta. Look at your palate, beta. Palate divides the nose from mouth. Would you agree? Palate divides the nose from the mouth, beta. If your palate is defective, your nose will mix with the mouth. If your palate separates the nose from mouth, if your palate is defective, it will create, mixture of the nose air with the mouth air, beta. So, any problem of palate will cause a rhinolalia aperta. What are the causes? Everything palate. Cleft palate, submucous cleft palate, palatal palsy, palatal perforation, palatal weakness, also called velopharyngeal insufficiency. Palatal weakness, also called velopharyngeal insufficiency. Velo matlab velum. Palate is a curtain. Look at me, beta. Palate is a curtain. Soft palate is a curtain. Velum mane curtain. Velopharyngeal insufficiency mane weakness, beta. So any problem of palate will cause aperta. Everybody, how to remember it? Write down aperta. A-P-E-R-T. P for palate, beta. P for palate. P for palate, beta. P for palate. Okay, bache? Aperta. P for palate. Okay, P for palate. So any problem of palate will cause aperta. Let us revise once again, beta. The causes of rhinolalia aperta, everything palate. Number 1, cleft palate. Number 2, submucous cleft palate. Number 3, palatal paralysis. Number 4, palatal perforation. And number 5, palatal weakness, also called as velopharyngeal insufficiency. My basic rule to remember is aperta has a P for palate. Any problem of palate will cause a rhinolalia aperta. Any problem of palate will mix the nose with the mouth air. So it will be hypernasality of the voice. Means the nose will become more dominant, beta. Look at me. If you ever see a cleft palate child in your practice, beta, then what will happen? When cleft palate is there, look at me, beta. When cleft palate is there, nose is mixing with the mouth. Nose air is mixing with the mouth air, beta. Now this poor child with cleft palate will say Baba. He says Baba. The sound produces Bama. He says Baba. The sound produces Bama. Like that. He said Baba, but the sound produces Bama because nose contributed. Nose got more dominant in the voice. Hypernasality. Baba becomes Bama. Like that. Rhinolalia aperta or hypernasality of the voice, beta. Okay, fine. Chalo, beta. Okay, can we go further? Now, the third one is rhinolalia clausa. Clausa means close. Close, beta. Just close nose, beta. Clausa, close nose. Clausa, close nose. Okay? Nose is closed, beta. Nose is blocked, beta. Clausa means nose is closed. Nasal polyp. If your nose is full of polyp or a tumor or nose is full of some other mass, there's no air. If there's no air, what will contribute? Nothing. Hyponasality means nasal component is less. Nasal polyp, adenoid hypertrophy. We'll discuss the next topic. Adenoid is behind the nose, beta. Adenoid hypertrophy. Adenoid is behind the nose. It grows like a big mass. You tell me, beta. If nose has blocked from behind, closed from behind, how the nose air will go in the mouth then? And a tumor, angiofibroma. Any mass-like lesion which closes the nose, which blocks the nose, that called rhinolalia clausa, hyponasality of voice, beta. Once again, let us read, beta. Let us see. Rhinolalia clausa. Clausa is closed nose. 3 causes to remember. Nasal polyp will close the nose, adenoid hypertrophy close the nose, and angiofibroma tumor will close the nose, beta. All these things which close the nose, which block the nose will cause a rhinolalia clausa or hyponasality of voice, beta. Now number 4 is functional aphonia or hysterical aphonia, beta. Functional aphonia or hysterical aphonia. Functional aphonia or hysterical aphonia, beta. Functional aphonia or hysterical aphonia, beta. Functional aphonia or hysterical aphonia. Guys, please, it's a psychological problem, first of all. It's a functional matlab psychological problem. Functional matlab drama. Just write on side. Patient is doing drama. Just to make it simple. Drama. Patient is doing drama over there, beta. Patient is doing a drama over there. Drama. Patient has no problem, but patient is trying to create a scene, a drama over there. Hysteria means create a scene. Patient is pretending the symptom of loss of voice. Pretending means acting. In a simple language, acting, beta. Patient is pretending the symptom of loss of voice. Actually, there is no problem. Actually, the voice is normal, beta. Actually, the voice is normal. Actually, the voice is normal, beta. Patient is pretending the symptom of voice, but actually the voice is normal. So patient is doing drama. There's no problem, beta. Functional patient. You say functional patient. It's a very common diagnosis. No, it's a functional patient, beta. Please understand, beta. Please understand. We all are functional sometime in our life, beta. Remember school time? So school time, today you have a maths test and you're not prepared. You had a cousin marriage, you were busy in that, you did not attend, you did not really, revise anything of the maths test, and maths teacher is cruel teacher. He's going to really give you a real good one. Now you are scared. You're scared. Today is a test. Now you, in the morning, 5:30 a.m., when your mom wakes you up, you go to your mother and you tell her, I have a bad stomach pain. I have a bad stomach pain. I go, she's a kind lady, mothers are generally kind, creatures. She will say, okay, take leave today. No problem. Take rest. And then you go and you sleep in the same bed again. At 8:30 a.m. in the morning, you go to the street and you start playing. I'm sure some of you would have done it for sure. That is also functional. You're doing acting of the stomach pain. Huh? Same here. This lady, this patient wants to attract the attention of everyone to herself, and that's why she's pretending the symptom of loss of voice. Actually, the voice is normal. Okay? More common in young female, beta. More common in young females. Sorry, ma'am. Sorry, ladies. But more common in young female in the bracket, especially 20-year-old. 20-year-old, beta. More common in young females, particularly 20-year-old, beta. 20-year-old. Okay? So typical question of MCI, beta. Very common question. 20-year-old female presenting with sudden loss of voice. 20-year-old female presenting with sudden loss of voice. What is the possible cause? Functional aphonia, beta. Just be careful, but. Just be careful. Okay? Imagine you are the emergency medical doctor in the hospital after your internship is over, and some family come, 4 or 5 members of family come with their daughter. When they say, our daughter has lost her voice suddenly, and you ask, what is the name? You say Anushka. They say Anushka. What is the age? You say 20 years. You recall this lecture or ENT lecture. So 20-year-old female, loss of voice, sudden, get lost. Chalo bar, kuch nahi hai. Don't do like this. As we get lost, chalo, bar chalo. Nothing like that. You are the patient is absolutely fine. It doesn't mean that every 20-year-old female with sudden loss of voice has functional aphonia, beta. It doesn't mean that. There may be some other genuine cause. Over there, beta. So first prove the diagnosis. How to prove the diagnosis, beta? This is a very important question. MCQ. How to prove diagnosis? Very simple. Cough sound is normal. Cough sound is normal, and this proves diagnosis. Cough sound is normal and this proves the diagnosis, beta. Cough sound is normal and this proves the diagnosis. MCI question, beta. 20-year-old female with sudden loss of voice and cough sound normal. What is the possible diagnosis? Functional aphonia, beta. This is the cough sound. Cough is also sound, by the way. Cough sound comes from the vocal cord. Cough sound comes from the vocal cord, na? Cough is a sound actually. Cough is a sound, and that comes from the vocal cord, beta. Guys, but do not do stupid mistake. You want to elicit cough sound? You want to elicit cough sound, beta? This lady is super intelligent. This 20-year-old female, college-going female, is super intelligent female, let me tell you. She has convinced 5, 6 family members of her family, very elder family members, and all of them are convinced that their daughter has got a genuine problem and she has lost her voice, and now the next target is you, beta. Now next target is you. And if you don't act smart, she will confuse you. Now she's looking at you. She wants to make sure that you are also trapped actually. The doctor is also trapped. So now if the patient is intelligent, we are also intelligent. Don't you think so? If patient is smart, we are also super smart. Now, don't go to her and tell her that, ma'am, cough please. Now if you, sorry ma'am, it's sir actually, ma'am, cough. If you tell this girl that, ma'am, cough please, now she's an intelligent lady. She will say, why she's asking me to cough? And now she got an idea that cough is important for you to make some diagnosis. Now she will never cough. अब उसको खांसी आएगी तो भी नहीं करेगी. Even if she wants to cough, she will never cough. You have given an idea to her now. If she is smart, you're also smart. Put a stethoscope, stand behind her and auscultate like this. Auscultate like this from back, and while auscultating, if she is acting, you're also acting with her. है ना? While auscultating, ask her to cough. Now she has seen in some Hindi movies, some Telugu movies that every time doctor puts the stethoscope on the chest, generally doctor say, खांसी करके दिखाइए, खांस के please cough please. And the moment you say, ma'am cough please, and say, the once she coughs, the diagnosis is ready with her. Okay, so cough has to be elicited. Thank you very much. Cough has to be elicited, but not patient should not know that cough is important for you. Are you getting my point? Okay, so because she is intelligent, you are also some intelligent, है ना? So vocal cord movements are normal. Vocal cord movements are normal, यार. वो तो कुछ भी नहीं है ना? It's an acting treatment, psychotherapy, not speech therapy, बेटा. Psychotherapy, because it's a psychological problem, ना? Psychotherapy, not speech therapy. Speech therapy क्यों देना है? गला ठीक है, दिमाग खराब है. गला ठीक है, दिमाग खराब है. Larynx is okay. Mind is not okay. Brain is not okay. Psychotherapy or psychiatrist consultation, beta. Psychotherapy or psychiatrist consultation. Okay, psychotherapy or psychiatrist consultation, beta. This is the topic which has been asked multiple number of times. Let's revise this topic. What is the name of topic? Functional aphonia or hysterical aphonia. It's a drama created by the patient, beta. Patient is pretending the symptom of loss of voice, but actually voice is absolutely normal. This patient is acting over there. Now, this is seen in young female, beta. Every time the question will come like that, 20-year-old female presenting to emergency with sudden loss of voice, functional aphonia. How to prove diagnosis? Important second question. Cough sound is normal, and this proves the diagnosis. The one who can cough can speak also. The sound na. अगर आप खा सकते हो तो आप बोल भी सकते हो. This sound, the one who can cough can speak also. Okay. Vocal cord movement on examination are found to be normal. Treatment is psychotherapy. Don't write speech therapy. It's a psychotherapy, mind problem. Okay? Okay? Fine. Next topic, beta. Cancer larynx, beta. Cancer larynx. Somebody asked this question. Srinath, Srijit. Srijit has asked question. Common nerve injured in thyroid surgery, beta. Me and Dr. Vineet have put a common video on MIST channel, YouTube channel. You can see that video about the nerve injuries in thyroid surgery. You can just search, just see the YouTube channel of MIST. There is a common video between me and Dr. Vineet. We will discuss what are the nerves to be injured in what order, beta. Okay, that's a surgery topic. And Vikram has asked, any aspiration in omega-shaped epiglottis in laryngomalacia? No. Laryngomalacia baby does not aspirate, guys. Aspiration is not prevented just by epiglottis. Epiglottis is only 1/3 of the story, beta. Epiglottis is not going to create full protection. Epiglottis doesn't cover epiglottis is not the only factor to prevent aspiration, beta. There are other mechanisms also, like sensory nerve supply of the larynx and all that. Okay, fine. Okay, very good. Okay. Now, if you have any question, you can always, put in the group also, beta. That's not a problem, huh? Okay. Can we start cancer larynx, beta? Cancer larynx, first of all, it's more common in males, beta. It's more common in males in 40 to 60 years of age. Okay. Cancer larynx is more common in males in 40 to 60 years of age. Females do not get this cancer. Mostly males are getting this cancer, beta. Now, risk factor is smoking. Everybody, smoking is known. Number 2, alcohol also. You may not be knowing alcohol as a risk factor for this cancer, but yes, that is the case. Cancer larynx, the risk factor is smoking plus alcohol also. This cancer has 3 types, beta. Everybody, the cancer has 3 types, beta. Guys, can you tell me what are 3 divisions of larynx? Bolo, beta. 3 divisions of larynx, beta. Can you speak, beta? Number 1, glottis, supraglottis, subglottis. Same 3 cancer. Glottis cancer, supraglottis cancer, subglottis cancer, beta. Number 1, glottis cancer, beta. Anybody, what is glottis? Bolo dara. What is cancer? What is glottis? Vocal cord. What is vocal cord? True vocal cord. Yes. It is cancer of true vocal cord, beta. It is cancer of true vocal cord, and it's the most common site of laryngeal cancer. Most commonly, the cancer start from the vocal cord, beta. Okay. Most commonly, they start from the vocal cord. Okay, bache. Now, everybody, look at screen. First of all, let me show you this one, beta. The vocal cord cancer, how do it look like? Just see over here. Can you see glottic cancer, beta? Glottic cancer is the cancer of true vocal cord. Where are we right now, beta? This is your normal vocal cord. This is your other vocal cord, and there is a cancer with the yellow arrow, beta. Can you see vocal cord, and this is the vocal cord cancer, matlab glottic cancer. Now, can you tell me what will be the chief complaint of this patient, beta? All of you try this. What is the chief complaint of this patient? Chief complaint of this patient will be what? Hoarse voice. Very good. Hoarse voice, beta. है ना? Vocal cord problem is voice problem, beta. Okay? Chief complaint is hoarse voice. Next page, beta. Chief complaint is hoarse voice, beta. MCQ. Chief complaint is hoarse voice, beta. HOARSE. Hoarse voice. MCQ, beta. What is symptom of glottic cancer, beta? Hoarse voice, beta. Simple logic, beta. Larynx में there are only two symptoms mainly. What are two symptoms? या तो आवाज नहीं आ रही या सांस नहीं आ रहा. You know what? If the problem is vocal cord, voice is the problem. If some edema is there, some cancer is there, some other things are there, then breathing may be a difficulty. Vocal cord palsy is there, breathing may be a difficulty. Okay? So larynx has got major two symptoms: voice problem, breathing problem. Voice problem, breathing problem. Okay? Fine. So vocal cord problem, hoarse voice. There are no neck node metastasis. Anybody? Why? Write in the chat box, beta. Write in the chat box. I want you to answer this question in the chat box. I'm waiting for 10 seconds. There are no neck node metastasis in glottic cancer. There are no neck node metastasis in glottic cancer, beta. There are no neck node metastasis in glottic cancer. Why so? Can you write in the chat box, beta? Can you write in the chat box? Why so? Because what? Because vocal cord have no lymphatics. Very good. Everybody, did you answer this question? Vocal cord have no lymphatics, beta. Vocal cord have no lymphatics, beta. Vocal cord have no lymphatics, beta. Vocal cord have no lymphatics. Okay, very good. Yes. Very good, beta. Datti Vikram rightly said that vocal cord have no lymphatics, beta. Very good. Wasim, a lot of people are answering this question. Wonderful. There are no lymphatic drainage, beta. There's no lymphatic drainage, beta. Very good. Wonderful. Very nice. Great, beta. Very good. Thank you, Akshay. Very good. Pushpendra. Gaurav Mane. No lymphatic. Yes. Vocal cord have no lymphatics. Therefore, no neck node metastasis. Therefore, put an symbol. Therefore, good prognosis. Very good. Vocal cord have no lymphatics. So, there are no neck node metastasis. So, therefore, vocal cord cancer or glottic cancer has got a good prognosis, beta. Number 2, supraglottic cancer, beta. Supraglottic cancer. Very good, beta. Very good, Akshay. Very nice. Yeah, lymphatics are absent, beta. Very nice. Perfect. I'm glad that you are in sync with the class, beta. Supraglottis cancer, beta. Supraglottic cancer above the vocal cord. Most common site is epiglottis, beta. Epiglottis. Most common site is epiglottis. Epiglottis, beta. Remember, vocal cord upper covered by, partially covered by epiglottis. Supraglottis. Above the vocal cord is epiglottis. Most common site is epiglottis, beta. Clinical features. Clinical feature. Number 1, throat pain referred to ear, beta. Throat pain referred to ear. Throat pain referred to ear, beta. Very good, beta. I'm glad that you're participating in all this. Do participate, beta. Participating in all these questions on the chat would really make this class more interactive. I know it's a virtual medium, but we can always feel that, okay, we are together. And then nobody is judging you, beta. Nobody is judging you. It's not, nobody is evaluating you that, okay, you are the real champion. I don't want champions. I want everyone to pass the exam. I want you to understand, make mistakes here. You are allowed, you are welcome to make mistakes here, so that later on in the exam day, when you play the World Cup, you don't do the mistakes, same mistakes, beta. Okay, this is a gully match, beta. It's a gully match. It's not even a district match, beta. It's a gully match. Gully cricket is being played. The day you play the World Cup on the 4th of June, what I want is you do all the mistakes now, so that you know what mistakes I do, and you don't do those mistakes on that day. That's how we save you from those mistakes, beta. So we are not judging you, we are not evaluating you, we are just assisting you, beta. Feeling of lump in throat. Feeling of lump in throat. There is a mass in the throat. Feeling of lump in the throat, beta. Okay, lump in the throat. Some of you, beta, maybe having this feeling of foreign body sensation in the throat. मेरा गला साफ नहीं है. There is something stuck in my throat always. My throat is not clear, but that is not feeling a lump in throat, beta. Don't tonight when you revise the topic, you say, your brain will say, I think you have got feeling of lump in throat. I think you are smoking. I think you have developed cancer. I think you're not going to survive. Then why should you study? Then why should you study, beta? Brain बोलेगा कि भाई गले में कुछ हो रहा है, किच होती है ना, तुम्हें शायद सिगरेट पीते हो. ब्रेन बोलेगा हाँ कैंसर हो गया, हाँ बचना तो है नहीं, हाँ तो पढ़ने का फायदा क्या, सो जाओ ना भाई, सो जाओ. ब्रेन विल टेल यू 10 रीजन नॉट टू स्टडी एवरी नाइट. बेटा किल दैट थॉट. कोई कैंसर वैंसर नहीं है. दिस फीलिंग ऑफ फॉरेन बॉडी इन थ्रोट इज वेरी कॉमन अदरवाइज ऑल्सो. डू यू हैव डिस्फेजिया? नो. भर भर के खाते हैं छोले भटूरे कुलचे डोसा सांबर. डिस्फेजिया है नहीं ना. अदर सिम्टम आर आल्सो देयर ना. थ्रोट पेन रेफर टू ईयर, feeling of lump in throat, dysphagia. And number four, my favorite, hot potato voice. Hot potato voice, beta. Hot potato voice, beta. If you are now, look at me, everyone. Hot potato voice. If you are hearing, when you hear this word, and your brain is saying that this word came earlier also somewhere, but you are not able to recall where this word came, it means that your brain is perfectly normal brain. It means your brain is perfectly normal brain. This is the way brain works. Then when you revise this at tonight, when you go back, oh, epiglottitis also had same kind of voice. That was epiglottitis. This is epiglottic cancer. Oh, some mass there, some mass here, beta. ऐसे याद हो, ऐसे. अभी नहीं याद आएगा. अभी तो सिर्फ तुम्हें इतना लगा. This one you should feel, oh, this word has come earlier today in the class. Where it came, I'm not able to recall it. It means your brain is perfectly normal brain. Okay? Don't over criticize yourself. Try to love yourself the way you are. You are a unique creation of nature. Love yourself. Whatever you are for others, it's their business. But whatever for you, you should love yourself. You should like yourself. You should really, it's okay. It's just the way you are, beta. We are overcritical about ourselves. Our schooling system makes us overcritical about ourselves. They say us in a wrong way. You know what? Some of the other things. And then we start feeling that we are mediocre. We are not. We are okay. We are not brilliant. I don't want to be brilliant. I don't want to be brilliant, honestly. Being brilliant is really a load to carry, a very huge burden to carry. I don't want to become that. I'm just an average, common human man, human. I want to be like this only. But yes, I'm not really, I don't want you to be overcritical about yourself. Let's follow a scheme of preparation and let's follow the right path of preparation. After third revision, we'll be able to recall a lot of things better. Okay? Hot potato voice better. Okay. Now, subglottic cancer. Anybody what is subglottis beta? Remember, subglottis is the empty space in the cricoid ring beta. You draw beta. I hope remember subglottis is the empty space in the cricoid ring beta. Okay. This is a rare cancer. Now, if in this area there is a cancerous growth beta, what it will cause is stridor beta. Stridor. Chief complaint is stridor beta. You know why? Subglottis is only air, air and air beta. Subglottis has got no structure. If you remember, if cricoid is a ring, subglottis is the empty space in that ring. If that ring has got air space, if that ring develop a cancer inside that, the airway is obstructed. Whenever airway is obstructed, you have got a stridor beta. Okay? Now. Perfect. Now let us do tumor staging of laryngeal cancer beta. T1, T2, T3, T4. T1, T2, T3, T4 beta. Let us do that. T1, T2, T3, T4. T1. T1 is only one structure involved. Only one structure involved. Only one structure involved beta. T2, more than one structure involved. T1 is one structure involved. Okay. T2 is more than one structure involved. More than one structure involved. Okay. For example, look at me beta. If tumor involves epiglottis only, T1. If tumor involves epiglottis and vocal cord, T2. T3, vocal cord is fixed or immobile beta. This is the question possible in your exam. It has never come in MCI till date, but if the question comes, it will be of T3 beta. T3 is very classical thing. T3 matlab vocal cord fixed. Vocal cord fixed matlab vocal cord immobile due to cancer, and that's T3 beta. T4 is invasion of thyroid cartilage. T4 is invasion of thyroid cartilage, beta. T4 is invasion of thyroid cartilage. Okay, invasion of thyroid cartilage. Thyroid cartilage got invaded, beta. Let us revise this, beta. It has never come in your paper, but still, higher level questions. T1, bolo beta, bolo. T1, everybody speak up with me. Are you with me are you with me? Are you imagining that we are together? T1 means what? Only one structure involved. T2 means more than one structure involved. Okay? When I say tumor involving epiglottis, only T1. When I say tumor involving epiglottis and epiglottic fold, two things, T2. But T3, the classical thing, T3 means vocal cord is fixed or immobile, beta. Immobile or fixed vocal cord, 100% T3. And if thyroid cartilage is invaded, T4, beta. Now treatment. T1, T2 is radiotherapy. T1, T2 is radiotherapy, beta. T1, T2, radiotherapy. T1, T2, radiotherapy, beta. Radiotherapy. Okay. T3, T4 is total laryngectomy followed by radiotherapy. Total laryngectomy plus minus one more surgery, beta. Plus minus radical neck dissection surgery, beta. Radical neck dissection surgery. R&D surgery, beta. Plus minus. Okay, if there is no neck node, every tumor, there may be neck node metastasis, there may not be neck node metastasis. If there is neck node metastasis, then you do R&D surgery also. What is R&D full form? Radical neck dissection surgery, beta. Radical neck dissection surgery. Okay, followed by radiotherapy, beta. Okay, followed by radiotherapy. Treatment of choice for T1, N0, M0 glottic cancer nowadays. This is the latest thing, beta. Nowadays, treatment of choice for T1, N0, M0 glottic cancer means glottic cancer. Highlight the word vocal cord cancer, beta. For T1 glottic cancer, beta. T1 glottic cancer. नीचे लिख लो जाए. Laser is a better answer than radiotherapy nowadays, beta. This is a new thing. For T1 glottic cancer, laser is a better answer than radiotherapy. If particularly the MCQ is about T1 glottic cancer, I will look for the answer choices. If laser word is written over there, I'll mark laser as a right answer, beta. I'll mark laser as a right answer. Okay, bache? Fine. And one line after that. After total laryngectomy, patient has got permanent tracheostomy. Permanent. When you do laryngectomy, patient has got permanent tracheostomy. After total laryngectomy, patient has got permanent tracheostomy. Everybody speak with me, beta. Let's revise this topic. T1. Everybody T1. T1 is what? One structure involved. T2, bolo beta. T2, more than one structure involved. T3, vocal cord is fixed or immobile. Important question T3. T4, thyroid cartilage invaded. Treatment for T1, T2, radiotherapy. T3, T4, total laryngectomy. Big tumor, big surgery. Total laryngectomy plus minus R&D surgery. What is R&D? Radical neck dissection surgery. If there is a neck node present, metastasis present, then you do R&D surgery. Plus minus R&D surgery followed by radiotherapy. But nowadays, treatment of T1 glottic cancer has changed. If question particularly is T1 glottic cancer, treatment will be laser is better answer than radiotherapy, beta. Laser is a better answer than radiotherapy, beta. Am I clear, beta? Laser is a better answer than radiotherapy. Okay, fine. Chale aage, beta. Fine. Very good. After total laryngectomy, patient has got permanent tracheostomy, beta. Permanent tracheostomy. Okay. Now let me show you. Now please see, this is the incision. This is total laryngectomy surgery, beta. You elevate the flap, beta. Okay, fine. Now this is what, beta? Which cartilage? Thyroid cartilage. This is cricoid cartilage, trachea, beta. Thyroid cartilage, cricoid cartilage, trachea. You separate from this side, then separate from above also, beta. Over here. Because you have to separate. This is laryngectomy. You have to remove this much part. Laryngectomy, you have to remove this much part, beta. Okay, fine. You separate it from sides, you separate from above, and then you separate it from below also, beta, from the trachea also. Did you notice? Okay. Did you notice that, beta? We just separate from the trachea also, beta. Okay. Then now you are saying goodbye to larynx, beta. Okay, please hear. The larynx has been removed. Total laryngectomy has been done, beta. Okay. Now what to do with the trachea? Now trachea is left only over here now, beta. Please understand. The specimen went out. Only trachea is left. Into the tracheal stump. Now what to do with the trachea, beta? Please understand. It's a very tricky situation. Now only trachea is left over here, just up to the sternum, beta. Either up to clavicle is at this level. After that, nothing is over here, beta. How to fill this gap now? ऐसा तो है नहीं that you can pull the trachea like a bamboo and like fix it or stitch it behind the nose so the air goes there. That's not possible. It's not a spring, beta. It's not a spring, na, that you can pull the trachea and stitch it back to the nose. That's not possible. Now what to do, beta? Because larynx is gone. There's nothing over here. How to maintain the continuity of the air now? So the air goes into the lungs actually. Now the only option left is you have to stitch the edges of the trachea to the edges of the skin, beta. Permanently suturing the edges of the trachea to the edges of the skin of the neck. Okay? Look at screen, beta. When the surgery is about to end, you make a hole or make a cut in the skin of the neck, beta. Did you notice that, beta? Now please see. I am stitching the edges of the skin with the edges of the trachea, beta. This is skin. And after 7 days, beta. This is the, please see. The edges of the skin have been sutured to the edges of the trachea. Now there is no connection upstairs, beta. Larynx is gone. The air has to go from here into lungs and come out of here only, beta. This, after 7 days, you remove the suture. Now this hole will be permanently visible in the neck of the patient like this forever, beta. It's a permanent hole in the neck of the patient. Now this hole will not be closed, beta. Now there is no connection over here, beta. There's no connection upstairs, my dear friends. There's nothing over here, beta. Nothing over here. This is the end. The trachea is here, beta. You suture the edges of trachea to the skin. Now air go from here, air comes out from here, beta. Okay, fine. This is trachea, and then the bronchi, beta. Okay, so the air is going from here like that. There's no connection upstairs. You are not breathing from nose. You're breathing from the neck now. This is the direct entry into the lungs for the air. You don't breathe from here, you breathe from the neck hole actually. Am I clear, beta? Fine. Now, can this patient speak, beta? Laryngectomy has been done. Can the patient speak? Technically no, na, but science can help him. We can train the person to speak still with special things like, next topic, beta. Next topic is the voice production after laryngectomy, beta. Next topic, everybody. Voice production after laryngectomy. Just draw a line, beta, beta. Just small thing. 3 methods, beta. There are 3 methods. Number 1, esophageal voice is a poor method. The basic method is you can train the person to speak using esophagus with speech therapy training, but it's a very bad method, beta. Poor method. It's impractical, it's useless, only namesake. The second one, very commonly uses this one, beta. Electrolarynx or artificial larynx. This is very, very common. Electrolarynx or artificial larynx. It is, what is, it is battery operated. It is battery operated external vibrator. It is battery operated external vibrator, beta. There is a charger with it. There is a battery inside this device. You have to keep it in the pocket of yours. And when you want to speak, you have to use it, beta. It's a battery operated external vibrator. It's an external instrument, beta. It's called electrolarynx or artificial larynx, beta. Electrolarynx or artificial larynx. Look at screen, beta. How we use it? Like this, beta. You charge it and then you touch it like this, beta. Over there, beta. Can you see? This is approximately, this is the length of the device of this much device. You just charge it, keep it in your hand, and when you want to touch, when you want to speak, this is the vibrating surface. You touch it like this. You touch it like this, and then you can speak. It costs around 6,000-7,000 rupees. Very affordable. Very, very successful. There's an electrical sound, but you can understand it. Doctors can understand it. Our ears are tuned. Families start understanding within a week time, and people can communicate very easily, beta. Very easily. It looks difficult, but after a few months, people adapt to it. Families adapt to it. They start communicating with the patient very effectively. but it's external vibrator. It's dependent on a battery. But I saw a patient in one of the OPDs. The patient came after 3 months of surgery. He has started using the vibrator, this electrolarynx or artificial larynx, and he came with his wife. In the OPD, he and his wife started fighting on some point, on some issue. They had a fight in the OPD only. Now the wife was speaking from here, and this guy was replying from here. The fight was going on pretty well. The match was going equal. She was saying something from here, and he was replying like this. And full force fight was going on, but suddenly the battery got drained. The battery got drained, and this poor chap lost the match. Lost the match, beta. Can you fit something in the body which can make you speak without need of any battery, beta? In the body, inside the body. Write down what is that? Number 3. Number 3 is tracheoesophageal puncture device, beta. Number 3 is tracheoesophageal puncture device. TP device, tracheoesophageal puncture device. Example is Blom Singer prosthesis. Blom Singer prosthesis. Its internal device, it is a unidirectional valve. Blom Singer prosthesis, it's an internal device. Electrolysis artificial device, external device, this is internal device. This valve you fit between trachea and esophagus. What is the name of device? Tracheoesophageal puncture device, beta. TEP device. Tracheoesophageal, TEP device. Tracheoesophageal puncture device, it is internal device. You fit in the body, okay? And in the bracket, it is a unidirectional valve, beta. Can you see the valve-like thing, beta? And when you fit in the body, it looks like this, beta. This you put it surgically, beta. Okay, this is way. Can you see TP device, beta? This is the tracheostomy hole, beta. Tracheostomy hole, and this is the posterior wall of trachea, and through that you can see a valve-like device over there. This is the TEP device, beta. Tracheoesophageal puncture device, beta. TEP device. Am I clear, beta? Let us revise once again, beta. Voice production after laryngectomy. Number 1, esophageal voice. Poor method. But number 2, this one is electrolarynx or artificial larynx. It is a battery operated external vibrator. Like this. But the best one is the third one. The third one is tracheoesophageal puncture device. What is the example of that is? Bolo beta. What is the example is? Blom Singer prosthesis. It is a unidirectional valve. It's an internal device you put in the body like this, and this helps you speak without the need of any battery actually. Okay, fine, TEP device, beta. But my dear friends, the hole will be there always in your neck, beta. This hole, beta, will be there, beta. If you are thinking, Rajiv, this can cause infection. Yes, it can cause infection, beta. With direct entry into lungs, you have to, keep it covered with something. If you think flies can go inside, yes, they can go inside, they can roam around, and they can come out also. Can you jump in the swimming pool with it? No, you will die in an instant, beta. The moment you jump in the swimming pool, the water will directly fill into your lungs and you will just die. Can you take a shower? That will be antim shower, beta. That will be your last shower. The moment you switch on the shower, the water will go into your lungs, aspirate, and you die. You know what? Hana? But people learn to live with it. People learn within 2, 3, 6 months, they learn to live with it. They keep it covered with some cloth. They will wear some high collar shirts and all that, and they will learn to survive with it. Am I clear, bache? Fine. So this is actually the electrolarynx, or this thing. But people learn to live with it. But I remember one patient who got super comfortable with the tracheostomy like this. He had laryngectomy done 6 months back. AIMS New Delhi OPD. I remember. What he was doing there, in the OPD, in the evening, he came for follow-up after 6 months of surgery. You know what he was doing, this bugger? He was smoking from here. इधर से बीड़ी पी रहा था, यहाँ से ऐसे रख के ना, इस होल में से, इधर से, यहाँ से बीड़ी रख के, सिगरेट रख के, यहाँ से बीड़ी पी रहा है. इतना comfortable हो गया. So much comfortable that he started smoking बीड़ी from here. Then one of the PGs asked him, Baba, what are you doing? Again you started smoking? Baba was super cool. Baba. So Baba picked up his electrolarynx, switched on the electrolarynx, kept it over here, and he told him, in Hindi he said that. Hindi said, जो होना था हो गया, अब सब ठीक है. अब सब ठीक है. In English he said that whatever had to happen has happened. Now everything is all right. No problem. I'm absolutely all right. Now this PG said, Baba, you know, you smoke from here now. You can get lung cancer also. बाबा को तुम बीड़ी पीते रहे ऐसे तुम्हें लंग कैंसर हो जाएगा. बाबा was super chilled out. बाबा ने स्विच दबाया, बाबा ने यहां रखा, एंड बाबा says that मुझे आप में पूरा भरोसा है, आप उससे मुझे बचा लोगे, उससे मुझे बचा लोगे बेटा. In English he said that I trust the doctors and they will save me from the lung cancer also. So I am absolutely all right. So the life goes on, beta. You feel that, you know, after tracheostomy, this kind of permanent hole in the neck, the life is not really that great. After a few months, the people adapt to live with it and they start living their life pretty okay. Not great, but pretty okay. Okay. This is electrolarynx. This is a laryngectomy in 3 ways how you speak after laryngectomy. Okay. Ciao. Now let's go further, guys. Now the next one. Level of neck nodes, beta. Level of neck nodes. Okay, level of neck nodes. 1A submental, 1A submental, 1B submandibular, beta. Neck node are 7 level, beta. Write down, beta, 1 to 7. 1 to 7, beta. 1 to 7. Total level of neck node 1 to 7. Pramod. 1 to 7. 1A submental. 1B, beta, not LB, beta, 1B. 1 has got 2 types, 1A, 1B, beta. 1A, 1B. 1A is submental, 1B is submandibular neck nodes, beta. Submental and submandibular neck nodes, beta. Okay? Now, 2, 3, 4. All of you draw the muscle. This muscle is sternocleidomastoid muscle, beta. Sternocleidomastoid divide to 3 parts like this. 2, 3, 4. 2, 3, 4. 2, 3, 4. Upper deep cervical, middle deep cervical, lower deep cervical. Jacket to that. Upper deep cervical, middle deep cervical, and lower deep cervical. Beta. Okay. Deep to which muscle? Deep to sternocleidomastoid muscle. So below the upper 1/3 are the level 2 upper deep cervical, below the middle 1/3 are level 3 or middle deep cervical, and below the lower 1/3 are lower deep cervical or level 4, beta. Level 5 is posterior triangle. Posterior triangle also called as supraclavicular. Supraclavicular lymph node, beta. This is MCQ, beta. Supraclavicular lymph node. Posterior triangle also called supraclavicular lymph node, beta. Supraclavicular lymph node. Level 6 is anterior compartment or pretracheal, also called as Delphian lymph node, beta. Delphian. Delphian lymph node, DELPHIAN. Okay. Level 6 is anterior compartment or pretracheal or Delphian. DELPHIAN. Delphian lymph node, beta. Delphian. Delphian lymph node. And level 7 is mediastinal lymph node, beta. Level 7 is mediastinal lymph node, beta. Mediastinal lymph node. Level 7 is mediastinal lymph node, and a doctor must know these levels, beta. Neck node, okay, anatomy, and otherwise in your clinical life also you'll need it. We have another person to help us. Either better, better. Now, please see. Now this is the mandible, beta. Mandible, mandible. This is 1A. 1A is submental. Okay. Then mentum is chin, है ना? Mentum, submental. 1B is submandibular, beta. Okay, here, when you touch this area, this is 1B. Now look at this one, beta. Look at this one. What is this muscle, beta? Can you see this muscle? This muscle is sternocleidomastoid muscle, beta. Sternocleidomastoid. Now let us divide this muscle into 3 parts. Upper 1/3, middle 1/3, lower 1/3. Below the upper 1/3, when we palpate our finger like this is which lymph node? Level 2 or upper deep cervical. Then we come below the middle 1/3. When we palpate like this lymph node is level 3 or middle deep cervical. And then finally, below the lower 1/3, we have got level 4 or lower deep cervical lymph node. Deep to which muscle? Sternocleidomastoid muscle. Then we have another muscle here, beta. Please see. We have another muscle. This muscle is what? Trapezius, beta. You know trapezius? Sternocleidomastoid and trapezius. And this triangle is called posterior triangle. If you touch your posterior triangle, this is above the clavicle, beta. Clavicle. Now this is called level 5 or posterior triangle lymph node or supraclavicular, because this is right above the clavicle. And finally, level 6, beta. Level 6 is here, beta. Here. This is pretracheal. Pretracheal, also called as anterior compartment. Is it anterior compartment? Anterior compartment or Delphian lymph node. Beta. Delphian lymph node. And level 7 you can palpate. That's in the mediastinum or in the thorax or chest. Beta. So once again, beta, revise with me. 1A submental. Everybody 1A submental. 1B submandibular. Now 2, 3, 4. 2 is upper deep cervical, 3 is middle deep cervical, 4 is lower deep cervical, and level 5 is posterior triangle or supraclavicular, and level 6 is anterior compartment or prelaryngeal or Delphian lymph node, and level 7 is mediastinal lymph node. Now what happens is, when you get a head and neck cancer, or oral cavity cancer, or laryngeal cancer, or other cancer, all these cancer have a chance of metastasizing to the neck node. Okay, neck node, and that's called secondary neck or the metastatic neck node. When you get a metastatic cancer or a metastatic neck node, you do a surgery called R&D. What is R&D? Radical neck dissection surgery. Beta. Okay, radical neck dissection surgery, if you see the next topic, R&D surgery, is better. Radical neck dissection surgery, if you see this topic, R&D surgery, beta, it's a surgery, read your notes, beta, it's surgery done in metastatic neck nodes, beta. When you get secondary neck node, you do the surgery called R&D surgery or radical neck dissection surgery. Now look at the name, beta, radical neck dissection, means you clear the neck radically. You don't want to leave a single cancer cell in the neck. For that, you remove the neck nodes. You also remove all those structures which are coming in contact with these neck nodes, so that not even a single cell of cancer is left in the neck. Beta. So what you remove is level 1 to level 5 neck nodes. Then you have to remove this muscle, beta. Write down number 2. Number 2, fill in the blank, beta. Number 2, which is this muscle, beta? Sternocleidomastoid muscle, beta. Sternocleidomastoid muscle. Why sternocleidomastoid muscle is being removed? Because this muscle is coming in contact with 2, 3 and 4 lymph node, beta. Then which vein is there, beta? Which vein is there? Internal jugular vein, and most of the neck nodes are lying around the internal jugular vein like beads, beta, like beads. So you remove the internal jugular vein also. Then there is a nerve passing from here, 11th nerve or accessory spinal nerve. And then finally we remove one more muscle, omohyoid muscle is here, beta. Omohyoid muscle, we also remove that. And finally 2 glands, beta. One gland is, which gland is this? Salivary gland. Which gland is there, beta? Yes, submandibular salivary gland. And this is parotid gland, the tail of the parotid gland. We are removing all these structures to clear the neck radically of all the cancer cell, and this surgery is called radical neck dissection surgery. Okay, thank you very much. Okay, radical neck dissection surgery. Okay. List of structures removed in R&D are level 1 to level 5 neck nodes. Number 2, sternocleidomastoid muscle. Number 2, sternocleidomastoid muscle, internal jugular vein, accessory spinal nerve, omohyoid muscle. Remember 2 muscle, beta, omohyoid muscle and sternocleidomastoid muscle. Omohyoid muscle and sternocleidomastoid muscle are removed. Tail of parotid gland and submandibular gland. 2 glands, 2 muscles, beta. Okay, tail of parotid gland and submandibular gland, beta. These are 2 salivary glands, beta. Basically, you are trying to clear the neck of all the possible cancer cells, beta. Am I clear? Fine. Let's revise. What is R&D surgery, beta? R&D surgery, radical neck dissection surgery. Everybody, what is the indication? This is done for metastatic or secondary neck nodes. We are removing lot of structure of the neck so that we clear the neck radically. We do not leave a single cancer cell in the neck. For that, we sacrifice a lot of structures, beta. Number 1, level 1 to level 5 neck nodes. Number 2, sternocleidomastoid muscle. Number 3, internal jugular vein, accessory spinal nerve, 1 vein, 2 muscle. 1 nerve, 1 vein, 2 muscle, and 2 glands, beta. Okay? 1 nerve is accessory spinal nerve. 1 vein is internal jugular vein. 2 muscle are sternocleidomastoid and omohyoid muscle. And 2 glands are tail of parotid gland and submandibular gland, beta. And level 1 to level 5. Not all, beta. Level 1 to level 5 neck nodes. This question comes in general surgery. They say all of the following are removed in R&D except. So you should know all. 2 muscle are removed, beta. Sternocleidomastoid and omohyoid, beta. Okay, omohyoid. Okay, fine. Now, let us do the last topic of larynx is tracheostomy related question, beta. Tracheostomy related question. Okay. Now, first of all, site of tracheostomy, beta. Most common site of tracheostomy. Before that, let us see the basic steps of tracheostomy, beta. Please see, this is your neck, and tracheostomy is an emergency surgery for the airway. First, you give the incision on the neck, and then you open up the neck quickly. It's a very quick surgery. It's an emergency surgery. Patient is dying. You quickly open that. Then you see the fat over there, the fascias of the neck. Then you open that also. Then you below that you see muscles of the neck. Which muscle? Strap muscle of the neck. You know muscle of the neck over there. You open them also. Then you just separate them, and then you see over there is a gland called, which gland? Thyroid gland, beta. Thyroid gland. Then you cut it in between thyroid gland. This is purple is thyroid gland, and then you expose the trachea, beta. Expose the trachea. Am I clear, beta? Then you expose the trachea, beta. Okay. Now trachea has been exposed. Now, everybody, just see over here, beta. Trachea has been exposed. Now, where to do the tracheostomy is the answer. Site of tracheostomy. Everybody, where to do the tracheostomy is the question now. Okay. Now, please see on the screen. Please see on the screen. This is what you have achieved by now. Okay. Now, if you can tell you, please see, larynx is here, beta. Larynx is here. Okay. Now. Okay. Now, this is your cricoid. Up to this is larynx. No? Cricoid is the final part. Now, then trachea comes. No? Trachea. First ring of trachea, second ring of trachea, third ring of trachea, fourth ring of trachea. First, second, third, fourth. Beta. Now, the question is, most common site of tracheostomy is second and third tracheal ring. Beta. We make a hole at here, beta. We make a hole in this area, beta. Second and third tracheal ring. Okay, beta. So, you make a hole at second and third tracheal ring, beta. Just see on the screen, beta. Let me show you. Just see on the screen once again, beta. Please see on the screen the same thing. Now, see over here. Where you are making the hole? Between second and third. Notice, beta, over here. You make a hole between second and third tracheal ring, bache. Am I clear, beta? Fine. Where you make the hole? This is cricoid. This is the first ring, second ring, third ring. You make a hole at second and third tracheal ring, and this type of tracheostomy is called mid-tracheostomy. Mid-tracheostomy, beta. Am I clear? Mid-tracheostomy. Okay, bache? Mid-tracheostomy. Now, all of you see the notes, beta. All you see the workbook. Now, this is called mid-tracheostomy. Now, we leave the first ring to prevent damage to larynx, beta. We leave the first ring to prevent damage to larynx. Okay? We leave the first ring to prevent damage to larynx, beta. Now, there is something called high tracheostomy. This is the MCI question, beta. High tracheostomy MCI question. High tracheostomy start from first ring. Write down, it is done at first and second tracheal ring. High tracheostomy is done at first and second tracheal ring, beta. High tracheostomy means high. Mid is 2 and 3. High is first and second. High tracheostomy is done at first and second tracheal ring. This is done for cancer larynx, and this is the popular MCI question, beta. What is the indication of high tracheostomy? Is cancer larynx, beta. Okay, it is done for cancer larynx. Normal tracheostomy is mid tracheostomy, and this is done at second and third tracheal ring. And the high tracheostomy start from first ring. This is done for cancer larynx, beta. Am I clear, beta? High tracheostomy start from first ring, and it is done at first and second tracheal ring, and mid tracheostomy is at second and third tracheal ring. 99.99% tracheostomies are done at second and third tracheal ring, but in cancer larynx we do high tracheostomy, and that is done at first and second tracheal ring. Am I clear? Now, next question. Tracheostomy reduces dead space by 50%. Very good. 50%. Tracheostomy reduces dead space by 50%, beta. Tracheostomy reduces dead space by 50%. Now look at screen, beta. Look at me, beta. What is the dead space? Physiology, beta, not ENT. I hope you know, from here to here, the air goes waste only. There's no exchange of gases happening in this area. The only exchange happen in the alveoli over here. Alveoli over here. Okay, the only exchange happen in the alveoli. So actual useful air is alveolar air. From here to here, the air goes waste in the passage. This is called dead space, beta. Now, when you make a hole here, you are breathing from here. At least this much effort is saved, but this much is still pending. Dead space is from here to here. When you make a hole over here midway, okay, and you breathe from the neck, this much dead space is, okay, 0 now, but this much is still pending. So tracheostomy reduces dead space by 50%, beta, 50%. Now, tracheostomy is a temporary procedure, except after total laryngectomy, beta. Remember, after laryngectomy, you will have permanent tracheostomy. I told you, after laryngectomy, there is a permanent hole in the neck. Otherwise, tracheostomy is only for few days or few weeks or few months, beta. But after laryngectomy, you have got permanent tracheostomy. Okay? One question of NEET PG. Tracheostomy can lead to apnea. Apnea means breathing stops. If you don't know apnea, write down apnea in the sidebar, use the sidebar. Apnea means breathing stops. Sometimes I've seen also, you give a cut on the trachea, suddenly the breathing stops. Oh, breathing stops, why? This is due to, technical word, this is due to CO2 washout. Tracheostomy will lead to apnea, MCQ, beta. This is due to CO2 washout, beta. Carbon dioxide washout. But the technical word is CO2 washout. Carbon dioxide washout, beta. CO2 washout. Okay. Now what is CO2 washout, beta? Everybody look at me, beta. Look at me. I hope you remember that carbon dioxide is a stimulus for respiratory center of the brain. CO2 in the blood is a stimulus for respiratory center of the brain, beta. Now, patient was having difficulty in breathing. That's why you are doing tracheostomy. Due to difficulty in breathing, the body was having retention of CO2. Blood was having high CO2 levels. But when in the evening you gave a cut on the trachea, the whole CO2 leaked from the body in one instance. The whole CO2 leaked from the body in one go. One go, it leaked. The blood CO2 level comes down. The brain respiratory center is stimulated by CO2 only. So CO2 stimulus is not there. For some time, the brain respiratory center do not get stimulated and the breathing stops for some time. But within few seconds, again CO2 accumulates in the body and again the respiratory center gets stimulated and the breathing starts again. But for some seconds after tracheostomy, breathing stops and that is called apnea. Tracheostomy leads to apnea due to CO2 washout. Okay. Next question is, tracheostomy can lead to surgical emphysema. Surgical emphysema. Tracheostomy can lead to surgical emphysema. What is surgical emphysema? It is air in subcutaneous area. Air in subcutaneous plane, beta. Air in subcutaneous plane, beta. Air in subcutaneous plane. Tracheostomy can lead to surgical emphysema. Underline the word surgical emphysema, MCQ, beta. MCQ. Let us not confuse emphysema with the emphysema of lungs. This is a very funny word. It is a very funny, confusing word and you might write emphysema thinking it's a lung problem. No. Surgical emphysema means there is some collection of air below the skin. Air in subcutaneous plane is technically called surgical emphysema. Air in the subcutaneous plane is called surgical emphysema. What do you mean by this? Look at me, beta. I hope you know in tracheostomy you have made a hole in the neck of the patient, beta. Okay, in the trachea. Don't you think so? From that hole of the trachea, what will happen? Some air will leak and that air will collect below the skin, beta. When you touch this skin of the neck, this air, beta, this green is the air. Now when you touch the, look at me, when you touch the skin of this neck, you will feel air crackles over there, beta. Because from the hole of the trachea, some air leaked from that hole of the trachea and that started collecting below the skin of the neck, and this collection of air below the skin is called surgical emphysema, or surgical emphysema is air in subcutaneous plane. In simple English, air below the skin is surgical emphysema. It has got no relation with the lungs, beta. So don't confuse. Surgical emphysema is air below the skin. Okay. Now the next question. Next question about tracheostomy is, tracheostomy tubes are, right? Give a heading, beta. Tracheostomy tubes, beta. Tracheostomy tubes, beta. Give a heading, tracheostomy tubes. Tracheostomy tubes of two types, beta, on the side. A, PVC tube. PVC means polyvinyl chloride. PVC means polyvinyl chloride is the name of the material, beta. The same material is used for the endotracheal tube also. PVC tube, polyvinyl chloride, PVC tracheostomy tube, beta. PVC, polyvinyl chloride, beta. Okay, fine. Polyvinyl chloride, beta. Okay, can we go further? Now, this is of two type, beta. Uncuffed tube and cuffed tube, beta. Without cuff and cuff. Cuffed are better. Cuffed are better, beta. This is cuff, beta. Label it, beta. This is cuff. Cuff is a balloon, beta. This balloon is called cuff, beta. This cuff is called balloon. This balloon is called cuff, sorry. Cuff is the balloon. There is a balloon around the tube. You can inflate the balloon, deflate the balloon depending on your need, but cuff tubes are better tube, beta. Now I'll tell you what is the advantage of cuff. Cuff, C-double-F, cuff. Cuff is this balloon name, beta. This is a better tube. PVC cuff tubes are better tubes, beta. Okay. Now what is the advantage of cuff, beta? Read your note, beta. Cuff decreases aspiration but leads to tracheomalacia. What do you mean by this aspiration business, beta? This patient is actually unconscious, ICU patient, very sick patient. He might aspirate continuously and lungs might get pneumonia. But this cuff is going to help you to prevent aspiration, beta. Kaise? How? Look at screen, beta. Look at screen, everyone. This is the cuff tube, beta. Let me show you. This is the cuff. Can you see the cuff, beta? Beautiful cuff there. This is the balloon, is called the cuff. Okay. Now, can you see this cuff? This is into trachea. This cuff is actually sealing the trachea. Now, even if you have got some saliva over here, beta. Saliva. Unconscious patient, some saliva is collecting over here, but saliva will not be able to go down because this cuff is going to block the flow, beta. This cuff is sealing the trachea completely. This yellow saliva is unable to go down our lungs, beta, over there. So patient will be saved from pneumonia, which is due to aspiration, which is very common in ICU patient, beta. Okay. But can you see this cuff is putting continuous pressure on the walls of trachea, beta. Can you see? This cuff is putting continuous pressure on wall of trachea, and this cuff can lead to tracheomalacia, beta. I can see that, beta. Look at screen, beta. Don't you see though? The cuff is putting continuous pressure on the wall of trachea, and this pressure might weaken the wall of trachea, and weakening is called malacia. So the cuff has one disadvantage. It can cause tracheomalacia. All of you read your note, beta. Cuff has got one advantage, one disadvantage. The advantage is it decreases aspiration. Disadvantage is it makes the trachea weak due to pressure, and that is called tracheomalacia. So what shall we use, beta? So we should use high volume, low pressure cuff. Look at your notes, beta. High volume, low pressure cuff, beta. Okay. So we should use high volume, low pressure cuff, beta. Am I clear, beta? Fine. Hence, high volume, low pressure cuff is better, beta. Am I clear? Fine. Now, next one is B, metallic tube, beta. Metallic tube is, example, Chevalier-Jackson tracheostomy tube. Everybody speak with me one time. Okay, Chevalier-Jackson tracheostomy tube, beta. It has two tubes, outer tube and inner tube. Inner is longer, beta. Outer tube and inner tube, inner is longer. This is the outer tube, inner tube, and inner is longer, beta. Tube in a tube, beta. Tube in a tube, outer tube, inner tube. And why two tube, beta? Because when you send the patient to home, then patient attendant need to take care. They can easily clean the tube, beta. They just remove the inner tube, they clean it, put it back. There is no worry. Patient attendant are very confident. They remove the inner tube, they clean it, boil it, dry it, put it back. Okay? They don't remove the whole tube, beta. So it is an outer tube, inner is a longer tube, beta. What is the name of tube? Chevalier-Jackson tube, beta. Okay. One question, very important, beta, and you should know this concept as a doctor, as an intern, because this is intern duty actually in the ward. Suction of the tracheostomy tube. The tracheostomy is full of secretion. You have to clear it, beta. With the suction, you have to clear it every 1 hour, 2 hours. You clear this, beta. If you don't do this, the secretion will get deposited in the tube, and the tube will be blocked, beta. Blocked. And that is a serious situation. Okay. Now, write down, beta. Come to the notes. Write down. If tube is blocked, put an arrow. Why? Due to improper suction. If tube is blocked due to improper suction, you did not suction it. You are an intern, nursing staff, or residents. They missed it. They did not. They just forgot to do the clearance, and the whole day, nobody did the suction. Sister thought intern did. Intern thought PG did. Nobody did. I have seen this happening in the R bar also. Sometimes it's a serious situation. But a tube getting blocked, the tube getting blocked due to secretion is a serious situation. Beta. First of all, write down. It is a serious airway emergency. A blocked tube is a serious airway emergency. It is serious airway emergency, but it is serious airway emergency. It's a very serious airway emergency, beta, because tube getting blocked is a serious airway emergency. Okay? Now look at me, beta. Now look at me, everyone. Look at me. Now the problem, what is the problem, beta? What is the problem? Everybody look at me, beta. Now what is happening is this tube is blocked. You were breathing from air and somebody did not do the suction properly and the tube got blocked with the secretions. This is exactly the same feeling. I asked one of the patient also, how were you feeling when this happened, beta? He told me only one thing, Rajiv, this was, the feeling was as if somebody has kept a pillow on my face and he's pressing the pillow on my face, beta. Have you seen in movies also? They keep a pillow on the face and try to smother the patient, beta. And what does the patient, what does the person do when somebody tries to push the pillow on the face, beta? He just pushes the pillow away, beta. Okay, the same thing you should do also. If you're intern, remove it immediately. Treatment, immediate treatment is remove it immediately and put a new tube, beta. Even if the new tube is not available, don't wait for the new tube, beta. Don't wait for new tube. There's a hole in the neck. At least from the hole, you'll get proper oxygen, beta. So if you get ever a question, the high level question of NEET PG, if you get the practical question are coming now, if the tube is blocked, they made a story like this in NEET PG paper. Hear me out. A patient underwent tracheostomy 1 week back. He's admitted in the ward. He has developed respiratory difficulty. His oxygen saturation is coming down. You are the intern on duty. What would you do? A, call the senior and wait for the senior to come. B, start oxygen immediately. Why would you wait for the senior, beta? You are a doctor also. Intern is also a doctor. Why would you start oxygen? Where the oxygen will go? The tube is blocked. Even if you put the oxygen here, there is no channel there for the oxygen go to the lungs, beta. Number 3, do suction. No, now the secretion are already dried up. Suction will not be able to clear it. 4th was remove the tube immediately. Intern must remove the tube immediately, beta. This hole in the neck will save the patient, beta. Okay? So this is the answer. Remove the tube immediately. Please answer. This is the practical question. You should know the doctor also. Forget about the exam. You're going to be future interns also. You should know it. Okay? Let's revise all the questions, beta. Let's revise all the questions of tracheostomy, beta. Let's revise all the questions of tracheostomy, everyone. Please look at the screen, beta. Let us revise, beta. Tracheostomy. Most common site of tracheostomy is 2nd and 3rd tracheal ring, and this is called mid-tracheostomy. Mid-tracheostomy. But in cancer larynx, we do high tracheostomy. High tracheostomy is done at the 1st and 2nd tracheal ring. MCA question, high tracheostomy, it is done for cancer larynx. It is done at 1st and 2nd tracheal ring. Tracheostomy reduces dead space by 50%. Tracheostomy is temporary procedure except after total laryngectomy. I know, after laryngectomy, you have got permanent tracheostomy hole in the neck. Tracheostomy leads to apnea, breathing stops. Technical word. Due to what? Due to CO2 washout. Tracheostomy can lead to surgical emphysema. What is surgical emphysema? It is air in subcutaneous plane. Air below the skin is technically called surgical emphysema. Tracheostomy tubes are of 2 types, PVC, polyvinyl chloride tubes, or metallic tubes. The PVC tube are of 2 types, cuffed and uncuffed. Cuffed are better tube. Cuffed are better tube. The advantage of cuff is it decreases aspiration, but disadvantage is it leads to tracheomalacia. Therefore, we use high volume, low pressure cuff. Okay. The metallic tubes, example is Chevalier Jackson tube, or it has got 2 tubes, outer and inner. Inner is longer tube. And if you don't do suction properly, the tube gets blocked. The question comes, what do you do immediately? Remove the tube immediately, and put a new tube later. But answer is remove the tube immediately. Okay. This was the end of the larynx, beta. Now, before we go further, let us do some questions of the larynx, remaining question, beta. We have done few of them. Now, please help me with these questions, beta. Few of them we have already done. In carcinoma larynx, CA larynx patient with stridor and respiratory difficulty, the tracheostomy is done at which level? अभी हमने किया. Cancer larynx tracheostomy is done at high tracheostomy. High tracheostomy. It is done at first and second tracheal ring, beta. Okay, don't write vertebra, beta. Don't write first and second. This is a wrong choice, beta. Okay, it's not a vertebra. You don't do tracheostomy at vertebral level, beta. Okay, it is first and second tracheal ring. The answer is C, beta. C. Okay, not this one, beta. Cancer larynx, high tracheostomy. High tracheostomy is done at first and second tracheal ring. Am I clear, beta? Fine. Okay. Now, which is the narrowest part of infant larynx? Try, beta. Infant pediatric larynx, narrowest part. Can you remember that, beta? Yes. Try it, beta. Try it. 47. The answer is B. Subglottis. Subglottis, beta. Subglottis. When you're seeing this video, you can pause it and think, and then see the answer, beta. Okay. There's a suggestion. If you want to think about it, pause it, think it, and then see the answer. B. Okay. Subglottis is the narrowest part of pediatric larynx. Next one. I hope you remember adductor palsy. Adductor palsy, type 1 thyroplasty, medialization, beta. Adductor palsy, type 1 thyroplasty, medialization. We have done the false chord being used to produce sound is dysphonia plica ventricularis. Remember, a singer, he is found to have adduction of false chord while phonating. What the name of disease is? Dysphonia plica ventricularis, means production of sound from false vocal cord. Okay? Now, yes, chalo, ye wala answer do beta. 20-year-old male patient has high pitch voice. Everybody, male with high pitch voice. What the diagnosis? Puberphonia. Puberphonia means a male speaking like a female. Laryngoscopy is normal. Clinician advice for speech therapy. In the speech therapy, he is asked to phonate while pulling the thyroid cartilage downward and pressing it backward, like this, pressing it backward. What is the name of the maneuver? What is the name of maneuver for puberphonia? Is the Gutsman maneuver, beta. Remember, Gutsman. Oh, man have guts, speak like a man. Gutsman. Puberphonia, what is the name of maneuver? Gutsman maneuver. Can you see it's such a big statement written? But if you know, oh, this puberphonia maneuver, Gutsman maneuver. Okay, a lot of time this, 3-4 liner question are one liner only, but they are only, expanded to make a story actually. But if you know, okay, puberphonia, Gutsman maneuver. Vocal cord lesion, all are true except, beta. All are true except, which is not true, except. All are true except, beta. Which is not true. First one is glottic cancer is associated with poor prognosis. Wrong. Glottic cancer has got good prognosis, beta. Why? Vocal cord cancer have got good prognosis. Why? Because vocal cord do not have lymphatics, beta. Do not have lymphatics. Okay? And keratosis larynx is a pre-malignant condition. Remember, smoker mein hota hai? You seen in smokers? Yes, it can convert to cancer, beta. Ringedema is best managed with decortication of vocal cord. Correct. Decortication is other name of stripping of vocal cord mucosa. Stripping. Decortication is other name of stripping. It is written in your notes also, beta. And which laser is used to treat juvenile papilloma? CO2 laser, beta. Okay, CO2 laser is used to treat juvenile papilloma of larynx. The answer is A, beta. Glottic cancer has got good prognosis, not bad prognosis, beta. A. Which of the following can lead to rhinolalia clausa? Clausa means close. Nose is closed, beta. Close. Closed nose, beta. Of course, it will be nasal polyp, beta. Polyp. Rhinolalia clausa. Nose closed, polyp, beta. Palate. Rhinolalia aperta. Okay, aperta. Remember, palate problem. This is also palatal weakness causes aperta. Nose closed, polyp, beta. Polyp causes rhinolalia clausa, beta. Answer is C. C, beta. Okay. Rhinolalia clausa. Nose is closed, polyp. Yes. Treatment of Singer's nodule. What is Singer nodule? It is other name of vocal nodule. But anybody, write in the chat box. I'm waiting for you guys. Vocal nodule, the treatment of choices. What is the answer? Yes, voice rest. No surgery, but D, voice rest or speech therapy. D, voice rest or speech therapy. Remember, vocal nodule, small laddu, keep your mouth shut. Apna muh band rakhna hai. Voice rest or speech therapy. Surgery wajri nahi likhna. Okay. What is not true about laryngomalacia? Laryngomalacia, what is not true about laryngomalacia? The laryngomalacia, what is not true is, about this is, inspiratory stridor, yes. Hoarse cry, wrong. Cry is normal, remember? Cry is normal, beta. Cry is normal, beta. Cry is normal. Cry is normal, beta. Okay? Treatment is conservative treatment. I hope you remember, laryngomalacia, you just reassure parents, beta. It is self-limiting condition. And omega-shaped epiglottis. Answer is B, beta. What is not true about laryngomalacia? I remember, in laryngomalacia, it is weakness of supraglottis, omega-shaped epiglottis, but vocal cord are normal. So voice or the cry is normal in laryngomalacia. Okay? Fine. I'm not expecting you to know the answer, beta. Believe me. You should not be knowing the answer at this moment. It's okay, no problem. But you should know the topic. Oh, this point was there in the notes. Only this much is required. Oh, this is to be observed in the notes, beta. This is what the utility of the MCQs. You must solve a lot of questions for every subject, beta. Reading notes is one thing, but solving question is also important. Solving question has got few advantages. What? Number one, you get to know which part of the notes are more important. Number two, what type of question are being asked out of those topics. Okay. Number three, what are the common silly mistakes I do while attempting this question so that I don't do this question in the exam, beta. Okay. And sometimes you get more clarity on the same topic while solving the question. And you get to know, oh, this point has to be compared like this with the other disease, beta. So solving question, please do not really leave that every day. Please invest some time in solving question out of Telegram, out of the missed question PDF, out of Tuesday, paper, out of the various, YouTube previous year papers discussion. At least last 4 session question are important. Choose one thing, but every day you must do certain question practice for sure. Okay. Now, everyone, look at now. Everybody, this is a pediatric question, beta. In a child with suspected diagnosis of epiglottitis, indicate your first line of treatment. First line of treatment, beta. First line of treatment. Epiglottitis was an airway emergency. If you remember, it's a very sick baby, beta. It's a very sick baby, an airway emergency. So, answer is airway by intubation, beta. Don't go for X-ray, don't go for the throat swab, blood culture, laryngoscopy. Straight away intubate the patient, beta, because it's a very sick baby. It's a serious airway emergency. Okay? Answer is D, beta. Okay? Fine. D. Which of the following airway obstruction cause inspiratory stridor? You know inspiratory stridor? Supraglottic obstruction causes inspiratory stridor. B. I hope remember supraglottic problem causes inspiratory stridor. Okay? Inspiratory, biphasic, expiratory. And below that is rhonchi wheezing is something else, beta. Okay, fine. All are true, but functional aphonia मतलब drama, acting, hysterical aphonia. Except it's a psychological disorder, yes. More common young female, yes. 20-year-old, yeah, okay. Patient is unable to produce cough sound, wrong. Cough sound is normal. Oh, normal. C is the answer, beta. Vocal movement are normal. Patient is unable to produce cough sound. No. Functional aphonia is drama, hysteria, hysterical aphonia, psychological problem. Patient has normal cough sound, beta. Answer is C. This is what is being asked in the exam, beta. Okay. We've done this one. Which of the following is the initial symptom of glottic malignancy? Initial symptom of glottic means what? Glottic means vocal cord cancer, beta. And this will be hoarse voice, beta. Glottic cancer, hoarse voice. Vocal cord problem, hoarse voice, beta. So, very easy question to attempt. Glottic malignancy is hoarse voice, beta. Okay, fine. Now, eyelid treatment for T1, N0, M0, glottic cancer, beta. Glottic. T1, glottic cancer. I told you, vocal cord cancer. Nowadays, it has changed to laser, beta. I told you, for T1 glottic cancer, laser is better than radiotherapy. I told you, if T1 glottic cancer come, T1, T2 radiotherapy. Okay, but T1 glottic nowadays, laser is a better answer than radiotherapy. Beta. T1 glottic means vocal cord cancer, laser is better than radiotherapy. Beta. Okay, fine. You've done this one. Now, 3-month-old baby with stridor, then cry of the baby is normal. Stridor is less in the prone position. What is the possible diagnosis? Please see, this 3-month-old baby, inspiratory stridor, cry of the baby is normal. The stridor is less in prone position. That is for sure laryngomalacia. Laryngomalacia, beta. Why it is not laryngotracheobronchitis? Laryngotracheobronchitis will be having fever and cough also. It's infection. This stridor is since birth, beta. Whenever in any specialty, the question says problem since birth, think of congenital anomalies of that problem. Think of when the problem is since birth, think of congenital disorders, beta. And why it is not laryngotracheobronchitis, beta? Because infection cannot be since birth. 3-month-old baby, he cannot be suffering from 3 months. Okay, fine. Cry of the baby is normal. Stridor is less in prone position. Stridor is since birth, actually. In the first week of life, it appears. All the things are pointed towards laryngomalacia. So now what I'm getting is laryngomalacia is an important topic. Same for medicine. CNS, when you do topic CNS question, Parkinsonism, epilepsy, stroke, multiple sclerosis, they'll come again and again and again. You get to, oh, Parkinsonism is important, epilepsy is important. So these things I should be doing better. Okay? So this is what the advantage of solving question is better. You get to know, not hard work, smart hard work better. Oh, this is more focus area better. Now, we've done this one. Which of the following cannot be seen on IL, beta? IL. I hope you remember anterior commissure, beta. I told you, remember, anterior commissure is hidden by the epiglottis, beta. Okay, anterior commissure is covered by the epiglottis, na? Partially covered by the epiglottis, so you can't see anterior commissure, beta. The rest of things can be seen, beta. Okay, now, these are the various questions of the larynx, beta. Yeah. Now, this was the today's session about larynx. I think we'll start the pharynx from the next day. Otherwise, there'll be a lot of gap because tomorrow is a holiday for you guys. We'll not really start. Some time is left. I'll say now. Let us end the day properly, beta. Now give me some time. Just 2-3 more minutes, and then we disperse, beta. I hope you have noted this Telegram group info for everyone. Now speak. Just listen me over here, beta. Everybody listen me. Now, please, guys. This is part 1 of the day is getting over for you. Part 2 is starting now. This is your time now. I hope you are not that tired. I hope you are not that exhausted. Please do share your feeling on the Telegram or on the app chat box. That how was your day today? Could you learn something? Did you enjoy the process of learning or not? Could you conceptualize the patient clinically? I'm not saying that you memorize it, but now when you are done with the day, share your thought with me so that we are able to connect, because online I really want to connect as much as possible with you, so that I also get the feel that which group of students I'm teaching and where they are located geographically. Now, for that, the only way is the chat or the Telegram or maybe email, which I shared with you in the beginning. Now, 7 o'clock, you just relax, beta. Make some coffee, tea, wash your face, or just straighten on your back, lie down for some time, then eat something little bit, maybe some fruit or something like that. Then 7:30 to 9:30, let us revise all the ENT larynx notes for 2 hours, finish it. Let us have dinner at 9:30 and relax till 10:15, 10:20, relax. After that, sit down again. If you're a night person, then please read some other subject. And if you're a morning person, you sleep early, then plan for the morning. But whatever you want to study tomorrow morning should be at the bedside, beta. At the bedside, and that paper should be folded from where you are starting, beta. You must put a bookmark over there. Brain wants to really, in the morning, the first alarm when it rings, you want to really snooze it. You want to postpone your getting up. You want to do some, नहीं उठा नहीं जा रहा, थक गया हूँ यार, अभी नहीं यार, अभी कल देखता हूँ यार, अभी नहीं पढ़ पाऊंगा. I can't do right now. I'm too tired. There's one holiday Tuesday. I want to take rest. Not at all, beta. For these 3 months now, we will be really, doing everything possible. whatever we can learn every day, we should do that. Okay? And what to do tomorrow, you should really put the book. For example, tomorrow you're revising, tomorrow revising surgery. So in that, your surgery, put the bookmark from where I'm starting, beta. If in the morning you will decide what you want to study, brain would not let you decide, beta. Brain would only suggest you to sleep. But if you are keeping a book on the bedside where you are sleeping, with the bookmark over there, with the pen over there, with rough copy over there, brain is conditioned whole night that moment you get up in the morning, this is what you're going to do. This brain is a wild monkey. You have to convert it to pet dog. How the wild monkey can be converted to pet dog? By giving it very strict, clear-cut instructions. That tomorrow morning when I get up at 6:30, I'm going to do surgery. My bookmark is ready. My rough copy is ready. My pens are ready. I'm there on this thing. My water bottle is also filled up for that. The whole night brain is channelized to do that better. But if you decide in the morning what you're going to study, you snooze the button and really sleep again. Better. We will not do that. T for Tuesday, T for 12 hours of self-study. Better. 12 hours, minimum 12 hours. How to do 12 hours? 2-hour session. Better. 2-hour session, break. 2-hour session, lunch break, 45 minutes, 1 hour break. 2-hour session, again break. 2-hour session, again break. You have a test also at night. But 12 hours of self-study should be the output in Tuesdays. Better. That is for sure. Okay? Like if you have to go for a run in the morning, for example, you're a jogging person or you're going to the gym. If you keep your tracksuit or your shoes ready, just close to your bed. Your tracksuit is lying in the chair next to your bed, and your shoes are lying very close to your bed only. The sports shoes. In the morning, my tracksuit is ready, my shoes are ready. I have to have a water bottle in the bag ready, and I have to go to the gym actually. So brain would not be able to confuse you because brain already got a clear-cut command. Last night only, everything is ready. I have to just get up and go in the morning. This works. This works better. Why I'm telling you all these things? Because I have wasted so much of time in my life by postponing. This is how I learned. Then I improved myself. This is what I'm telling you. This helps me better. It's not that I'm always organized. I'm really totally ill-organized. But certain point of time, I need to be organized actually. And these all things have helped me in my PG preparation days. And whenever I appeared in any exam like MRCS and all that, it really helps me. And I hope it helps you too. Okay. My only humble prayer to the Lord is that may you all pass better. May you all pass. That's a utmost, honest wish from my side. That may you all pass. May your parents be feeling blessed because they are trusting you. I know they have invested big time into you. May they get a good feeling, and let us try to work hard. But we will not get psyched up better. What if I fail this time? What I fail this time again? There are 2-3 time failure people all sitting, but it's okay, no problem. Are you doing your best or not? My humble question to all of you is, are you doing your best? My question to you is, are you just worrying, or are you doing your best better? What works is surrender to the Almighty better. Let's work up to the best of our abilities and leave the rest to God to decide. Whenever you feel scared, fold your hands and look above. I'm doing my part, you do your part. May God bless your hard work, beta. See you again Wednesday morning. We start the topic of pharynx, then we do the nose and sinuses on that day. And third day we do, part of the ear and then we finish it like that. Okay? Fine. Thank you very much. Please connect with me on the chat. How was the day for you? On the Telegram also, beta. Okay? Thank you very much. See you again on Wednesday morning. Bye-bye. Bye-bye. Smile and we can say goodbye.